Thank you very much for your patience. We will start the session from now on.
Hello everyone, I'm Dr. Hitoshi Kagaya. I chair this session. I'm from Department of Rehabilitation Medicine First, School of Medicine, Fujita Health University, Japan. So, this session, we have 5 speakers. Now let's start. The first speaker is Dr. Dumican from USA. His title is The Effect of Neuromuscular Electrical Stimulation on Hyoid and Laryngeal Kinematics in Post-Stroke Dysphagia. Dr. Dumican, please.
Thank you, Dr. Kagaya, for chairing this committee and for the rest of the committees on the summit for having me here. I really appreciate it. Good day to everyone, wherever you might be. I'm really looking forward to having this presentation presented to you, and I'm looking forward to answering any of your questions when it's over. Whenever you're ready, please feel free to play the presentation.
Start video, please. Is something wrong? Start the video, please. I think the movie does not move. Because this video is probably pre-recording, so what's happening?
On hyoid and laryngeal kinematics in post-stroke dysphagia. Thank you, everybody, for coming to this presentation. My name is Matthew Dumican, and today we'll be talking about the effects of neuromuscular electrical stimulation on hyoid and laryngeal kinematics in post-stroke dysphagia. Here are our disclosures of conflicts of interest to reference if necessary. So neuromuscular electrical stimulation, or NMES, has been widely used throughout therapy disciplines and across disciplines and diagnoses for decades, for a very long time. This has been done in order to improve neuromuscular functioning. Given the exposure that speech pathologists or therapists or SLPs have to NMES and the populations they often encounter with neurological and neurodegenerative diagnoses, the potential to use this modality is very accessible to speech pathologists. However, in using NMES or electrical stimulation, as some might call it, to treat dysphagia, there are many different available parameters and approaches that have been used throughout the literature. And what this does is provide very unclear evidence on how to appropriately implement specifically neuromuscular electrical stimulation to treat dysphagia. But not only this, the multiple different parameters and approaches have resulted in low quality evidence if using NMES can even treat dysphagia. Electrode placement of NMES when delivered is a main issue that leads to many of these mixed results. It's important to understand that NMES is designed to do two things. It's designed to generate muscular contractions, and it's designed to facilitate movement. But importantly, it's designed to do this together, to generate muscular contractions and to facilitate movement during active movements, to improve functioning progressively over time. So when using NMES for dysphagia, it's paramount to implement treatment in a way that accomplishes those treatment principles. Taking that into consideration, based on the physiological function of the suprahyoids to elevate the hyolaryngeal complex quickly and timely, suprahyoid placement and targeting of NMES is likely the most beneficial approach. Now again, this is based on the physiological function of the suprahyoids, and current evidence shows positive outcomes regarding NMES treatment when using a suprahyoid approach. However, these studies, while showing positive perceptual outcomes in patients, have not directly investigated why these patients experience improved perceived outcomes. Perturbation of the laryngeal vestibule is also a consideration of NMES, even though it's designed to be facilitative. It may be implemented in dysphagia treatment to create perturbations to specific aspects of, say, a laryngeal or upper airway closure. Now, studies using mixed parameters and electrode placements have found no significant effect of NMES on these kinematic timings previously, while others utilizing NMES and very specific placements and parameters on the suprahyoids have found improved laryngeal vestibule closure kinematics in healthy adults. So how do we tease out and separate conflicting results to determine if NMES is appropriate to treat dysphagia and what the appropriate parameters to use are? Well, investigating this using Ampcare's effective swallowing protocol might be a relevant way to do this. That's because of two things. One, as we've already discussed, is the use of suprahyoid only placement. The second is using appropriate NMES parameters in line with small muscle function. That includes utilizing sufficient frequency to create a muscular contraction, but also utilizing a lower phase duration that's appropriate without causing unnecessary fatigue or potential pain during treatment. And I think a good example of this is in the picture on this slide, where on the left you have a patient at rest with stimulation off, and then on the right, receiving Ampcare's ESP with stimulation on. So you can see both of these, one using suprahyoid only placement, creating improved hyoid elevation, but also using this in appropriate parameters to create enough of a contraction without causing unnecessary fatigue or potential pain in the patient. So Ampcare's use of placement and parameters, as well as previous positive outcomes related to patient reports, are really what led us to investigate why are these reports positive? Why are these patients experiencing improved perceived swallow function and quality of life? So we looked at changes related to the hyolaryngeal complex, including hyoid movement, post-treatment, as well as the laryngeal vestibule kinematic timings to see if they improved post-treatment, as well as investigating if measures of airway invasion like the penetration and aspiration scale improved post-treatment. So this was in a small clinical cohort diagnosed with pharyngeal stage dysphagia post-stroke, undergoing primary treatment of dysphagia with NMES, and all patients completed at least 30 days of treatment and a minimum of 30 minutes per therapy session with NMES and Ampcare's effective swallowing protocol as the primary treatment. We utilized TIMS DICOM system to analyze all hyoid and laryngeal vestibule kinematic measures, utilizing a standardized calibration referent. We utilized repeated measures, analysis, as well as a chi-square to examine the association of treatment condition with airway invasion outcomes. So our results. Our results indicated a significant effect of treatment for superior hyoid movement. So overall, subjects displayed significantly greater superior hyoid movement post-treatment with NMES than pre-treatment, indicating that progressively over time, patients were able to generate more hyolaryngeal movement superiorly with NMES. 7 out of 11 patients displayed significantly improved superior hyoid movement. There's also a significant effect of treatment for laryngeal vestibule closure reaction time, or how long it takes an individual to close their airway. Compared with pre-treatment times, subjects displayed significantly faster closure reaction times post-treatment with NMES. And this suggests, again, over time, patients were able to improve how quickly they can close their airway during swallowing after NMES as the primary treatment. And our overall outcomes were 10 out of 11 patients displayed a significantly faster closure time of the laryngeal vestibule post-treatment. Now, just as an example, this is a one case, but in terms of laryngeal vestibule closure reaction time, this is pre-treatment with the airway open to the time it takes to close the airway on the right. We can see that it takes approximately 0.27 seconds or 270 milliseconds for the airway to close pre-treatment. Whereas post-treatment in the same subject on the same bolus type, we can see that it takes significantly less time, only 0.133 seconds or 133 milliseconds for the airway to close in this subject post-treatment compared to pre-treatment, an improvement on the same bolus type of approximately 1.4 seconds or 140 milliseconds, which is approximately a 50% improvement in time to close the airway post-treatment. And finally, there was a significant association of lower or normal PAS scores with the post-treatment group. So this indicates not only did physiological parameters of structural movements and timings improve, but overall metrics of airway invasion and swallow safety were significantly more associated with post-treatment time points after using NMES. And descriptively, we can see this within subjects as well. We can see that 7 out of 11 patients improved their worst PAS score overall, but importantly, all patients displayed improved tolerance to bolus consistencies and volumes. So some considerations. NMES may be an appropriate and effective dysphagia therapy approach, both as a facilitative means, but also for perturbations to airway closure mechanisms. Substantial attention needs to be paid to electrode placement and electrode or NMES parameters when using NMES as a therapy approach. But of course, while we saw positive results in this small clinical cohort, more rigorous controlled studies adhering to more appropriate placements and parameters are needed to validate these outcomes. These are some references, and more references continued. Thank you. And
Thank you, Dr. Dumican. I don't see any questions from the audience. So it's a time for open discussion. So are there questions from the panelists? Okay, so I have one question to Dr. Dumican. So you showed the superior displacement of the hyoid bone after the therapy. So how about the anterior displacement of the hyoid bone?
Yeah, anterior was non-significant, as was, we measured overall excursion too, as a derived from the superior and anterior movement, and that was also non-significant. So the biggest difference we saw was in superior hyoid movement.
So do you think this product is more effective for the displacement of the superior direction than anterior direction?
Well, I want to be very cautious and clear that I'm not here to compare products per se, one versus the other. But what I will say is the parameters that were used were effective in generating these changes post-stroke. in dysphagia treatment. That's definitely what I would say. Again, cautiously stating, it was a small clinical cohorts, but I do think it's a step in the right direction to show what these particular parameters may be able to do in dysphagia treatment.
Thank you. Actually, I have this product.
Okay.
Okay, thank you. Okay, so let's move on the next speak. So this second speak is by the Dr. Ryu from Korea. His title is Compensatory Effects of Sequential 4-channel NMES for the Treatment of Acute, Subacute, and Chronic Dysphagia in a Prospective Double-Blinded RCT. Dr. Ryu, please.
Hello. Hello, my name is Won-Seok. Thank you for introducing me. And this is a confirmatory study. And as I prepare the video clips, I will show you the video first. Thank you. Hello, my name is Won-Seok Ryu. Our topic is compensatory effects of sequential 4-channel NMES for the treatment of dysphagia in a prospective double-blinded RCT. I have 4 patients regarding the medical device for treatment of dysphagia. Introduction. Though most clinical studies regarding 2-channel NMES have focused on rehabilitative mechanism, hypothetically, NMES could be used not only for the rehabilitative mechanism, but also for the compensatory mechanism. In previous studies, we found out the normal contractile sequences of swallowing-related muscles also improved the efficacy of sequential 4-channel NMES in clinical, kinematic, and pressure parameters in the pilot study. Our hypothesis is that compensatory application with the sequential 4-channel NMES on the suprahyoid and infrahyoid muscles would improve the hyoid and laryngeal motion during swallowing, as well as the swallowing function in patients with dysphagia. The purpose of this study was to prove the clinical efficacy of sequential 4-channel NMES for compensatory application during swallowing in a double-blinded RCT in these patients. Method. This study was a multi-center prospective double-blinded RCT. The study protocol was approved by the IRB and by the Ministry of Food and Drugs Safety in the Republic of Korea. This slide shows the inclusion and exclusion criteria. We also used the VFSS criteria to prevent ceiling effects. These figures show the sequential 4-channel NMES device and the locations of electrode attachment. Channel 1 and 2 electrodes are attached on the bilateral suprahyoid muscles. Channel 3 and 4 electrodes were attached on the bilateral thyrohyoid and other infrahyoid muscles, respectively. Channel 1 and 2 start their electrical stimulation first, and Channel 3 and 4 start their stimulation 150 and 250 milliseconds later, respectively. These sequential stimulations normalize hyoid and laryngeal motions. The initial VFSS, all participants were enrolled. They underwent a preparation process where the application of 4-channel NMES were familiarized for 1 and 2 sessions. For synchronous stimulation of NMES, patients push the start button and begin swallowing when the NMES pulls the suprahyoid muscles. For the intervention, study group underwent the 4-channel NMES while swallowing 5 ml of thin and extremely thick fluid twice. The sham group did not undergo the NMES during swallowing. Outcomes. VFS interpretations were performed by blended 3 researchers who certified MBS-IMP. The primary outcome was the VDS, and the secondary outcomes were PAS 5-point Likert scale to assess satisfaction, easiness, and discomfort during swallowing, and kinematic variables. For kinematic analysis of VFSS, we use the automated kinematic analysis software, ARCAS. This program traces a 2-dimensional moving trajectory of the hyoid bone automatically, then calculate the timing and distance variables. This slide shows the statistical analysis. results. This figure shows the flow of the trial. The demographic data of the participants are presented in Table 1. As you see, there were no significant differences in the demographic data, VDS and PAS, between the two groups. This slide shows the VDS data. This slide shows PAS and Likert scales. In a comparison between pre- and post-treatment evaluations, the oral, pharyngeal, and total VDS scores, as well as the PAS scores, were significantly improved in both groups. When we compare the changes between the two groups, the improvements of the study group were significantly greater than that of the same group with respect to oral, pharyngeal, total VDS, and PAS scores. The Likert scales for the satisfaction, easiness, and discomfort for swallowing showed favorable results for the study group. This table shows the results of kinematic analysis. Figure C, D, E show the results of kinematic analysis. The movement trajectory of the hyoid bone became larger and clearer in direction with NMES in thin, extremely thick, and whole fluids. I'll show you some representative videos. Left video is before NMES, and right video is during NMES. You can see prolonged and stronger contractions after NMES. This slide shows swallowing of honey-like fluid. After applying NMES, you can see the decreased residual material and prolonged contractions. Before NMES, you can see a lot of residue, but it was disappeared after applying NMES. You can see the aspirations on left side, but it was disappeared after applying NMES. This slide shows the decreased residue at vallecular porch and piriformis sinus after applying NMES. Discussion. In the EMG analysis of normal swallowing, the suprahyoid, thyrohyoid, and other infrared muscles are sequentially activated with intervals of 150 and 300 milliseconds. These sequential contractions accomplish the circular motion of the hyoid bone. Likewise, the thyrohyoid muscle assists laryngeal elevation, and other infrared muscles assist the US opening by producing prolonged anterior motion of the hyoid bone. Considering the improvements in subcategories of VDS, our present study demonstrated that the sequential functional NMES decreased the expression risk in the whole swallowing process. In this study, sequential NMES of swallowing-related muscles pull the hyoid-laryngeal complex in the anterior direction, so the strength of submated vector of the stimulated muscles was increased. This method was intended to improve the coordination and contractile strength of these muscles, thereby producing sufficient strength of the submated vector. Limitations. First, during the intervention, the patient knows the presence or absence of NMES and the blindness is broken. However, since the study was completed immediately after the test, it was described as double-blind. Second, the results do not apply to individuals with severe dysphagia who are unable to swallow liquids. Conclusions. A new method using sequential functional NMES on the suprahyoid, thyrohyoid, and infrared muscles during swallowing showed significant clinical improvement with respect to VDS, PAS, and kinematic analysis. Since no side effects were observed during the investigation, functional NMES seemed to be safe and well-tolerated treatment method for the dysphagia. Therefore, sequential functional NMES can be used as a new treatment method for the compensatory mechanism in patients with dysphagia. Thank you.
Thank you, Dr. Ryu.
Yeah.
So, no question from the audience. So, are there any questions from the panelists? Okay, I have a question to Dr. Ryu. So, did you stimulate at rest or did you stimulate during swallowing?
Yes, during swallowing. Yes, it's like a wearing robot. We apply functional NMES during swallowing, and it can be effective during swallowing.
So did you stimulate only during swallowing? only
Yes.
during swelling?
Yes.
Or
Yes.
not at rest? Okay. So how is it sequential? I mean, first did you stimulate suprahyoid and then infrahyoid? What so?
Yes. Firstly, we stimulate the suprahyoid muscles, and then 1 and 50 milliseconds later, the thyrohyoid muscle is stimulated. Then other infrahyoid muscle is stimulated. So suprahyoid, infrahyoid muscles prolong the hyoid more anterior sufficiently, and thyrohyoid contract the larynx. So, and this coordinated stimulation coordinate the hyoid movement and laryngeal movement.
Okay, so how did you determine the timing of the start of the electric stimulation during swallowing?
Timing, I mean, initially I checked the needle EMG study to the suprahyoid muscle, thyroid muscle, and other infrahyoid muscles. And I found that the latency and the durations of each muscle, such as the mylohyoid, digastric, thyroid, omohyoid, and sternothyroid muscles. And then we also applied the surface SEM study too, and it is the result were published in Science report this year. And so the sequence, we found that the sequencer normal control algorithm, and then the patient need to practice. When the patient push the button, and then the first suprahyoid muscle contract, and the patient start to swallowing. So NMES assists normal swallowing.
Okay, thank you. Any other questions? Okay, so let's move on the next speak. The next talk is from me. So my title is Electromyography Triggered Peripheral Magnetic Stimulation, Synchronized with Voluntary Swallow. Start my video, please. My talk is Electromyography Triggered Peripheral Magnetic Stimulation, Synchronized with Voluntary Swallow. I am one of the inventors of new coil for magnetic stimulation. Electrical stimulation therapy is effective for patients with dysphagia. However, strong stimulation cannot be applied because of the pain. Although magnetic stimulation induces less pain, there are no reports on magnetic stimulation being synchronized with the swallowing reflex. This study aimed to determine whether it is possible to induce magnetic stimulation during a voluntary swallowing using EMG-triggered peripheral magnetic stimulation, and to evaluate its effect on healthy individuals. We have already developed peripheral magnetic stimulation, PMS, for suprahyoid muscles by the new coil. This is a movie of hyoid movement at rest by PMS. You see the good hyoid elevation. The average for displacement is 10.9 mm, while upward displacement is 8.3 mm. Besides, median pain during PMS evaluated by numerical rating scale was 1. That means very little pain during PMS of suprahyoid muscle. We tried 20 healthy subjects. A specialized suprahyoid stimulation coil was set to this submental area. The coil was connected to a peripheral magnetic stimulator, which emitted magnetic stimulation at 30 Hz frequency for 2 seconds. To apply magnetic stimulation in sync with the start of a swallowing reflex without a delay, a possible option is using a contraction of the suprahyoid muscles as a trigger. However, it is impossible to place the electrodes on the suprahyoid muscles in this system because of coil for magnetic stimulation. Therefore, the surface electrodes were attached to the left sternohyoid muscle. EMG waveform of the sternohyoid muscle was a deconverted, sampled at 10,000 Hz, bandpass filtered at 20 to 500 Hz, full wave rectified, root mean square at 0.01 second intervals, and smoothed by a 5-point moving average. The threshold of the sternohyoid muscle activity as an EMG trigger was set at 10 microvolt beyond the baseline. Under video fluoroscopy, we instructed subjects to saliva swallows 4 times, 2 with and 2 without magnetic stimulation. Then, 10 ml of liquid volume swallows 4 times. Magnetic stimulation was applied by frequency of 30 Hz. Duration was fixed at 2 seconds, and the intensity was increased within the subject did not feel pain. Approximately 0.7 to 0.8 Tesla. We show you the movie of swallow of 10 ml of liquid volume with magnetic stimulation. Once more. A swallow without magnetic stimulation is like this. This is an example of the anteroposteriorly and vertically trajectory of hyoid bone by liquid swallow with stimulation. Magnetic stimulation was applied for 2 seconds. The hyoid bone elevated more with magnetic stimulation, but did not descend sufficiently until the stimulation stops. Hyoid movement time was longer both in saliva and liquid swallow with magnetic stimulation. In liquid swallow, maximum forward movement of hyoid bone was larger. UES opening width measured by anteroposterior diameter of the narrowest part between the 3rd and 6th cervical vertebra was bigger, and forward hyoid displacement at the maximum UES opening was larger. Pressure topography was evaluated by a high-resolution manometry with 36 pressure sensors. Maximum post-closure UES pressure was smaller, both in saliva and liquid swallow. This is probably because UES was pulled anterior by magnetic stimulation. This is the first report to concomitant use of magnetic stimulation during a voluntary swallowing. We succeeded in synchronizing magnetic stimulation with the swallowing reflex by using sternohyoid EMG. Magnetic stimulation pulled the hyoid bone anterior during swallowing and affected the UES pressure. Magnetic stimulation may hamper the hyoid bone from descending in the late stage of swallowing. Conclusions. We succeeded in the concomitant use of magnetic stimulation during a voluntary swallowing by employing sternohyoid EMG triggered PMS for healthy individuals. The concomitant use of magnetic stimulation lengthens the hyoid movement time, and the further anterior placement of the hyoid bone increased the UES opening width and decrease the maximum pre-opening US pressure. Applying this new technique to patients with dysphagia may help establish novel therapeutic modalities. Thank you for your attention. Thank you for listening my talk. So because there is no question from the audience, are there any comments or questions from the panelists?
Yes, thank you. I have a question.
Okay.
Excellent talk and very impressive results. I'm curious why you think that there was no change in UES minimum pressure, although there was a change in UES opening diameter.
Well, I'm not sure about that because we tried 20 healthy individuals, but only 6 was applied for high-resolution manometry because, yeah, you know, the high-resolution manometry is a very difficult task for healthy individuals. So it may be a statistical error or something like that. Anyway, okay. I'm not sure about that.
All right, thank you.
Any other questions? Oh, I have a question from the audience. First question is, did you analyze the position or transport of bolus during the swallowing? I'm sorry, the answer is no. I did not analyze the position of transport of bolus during the swallowing. Yeah, I should do probably, I think. Thank you for your question. The second question is, would it be better to be able to stimulate them as they are swallowing? If the stimulation starts before swallowing, is it possible that the timing of the stimulation may not match the swallowing reflex, making it difficult to swallow? My answer is, yeah. I tried this system both at rest or during swallowing. Actually, most of the stimulation was done at rest. But I think because the patient who has a reduced hyoid elevation, it may be better to stimulate simultaneously with swallowing. Okay. Yeah, the problem of my system is the duration between the delay of the stimulation start. In my another analysis, the timing of the start of this start of the suprahyoid muscle and infrahyoid muscle is about 0.2 seconds. Infrahyoid muscle start is delayed. So that may be a problem, but I think still it may be effective. Okay. Thank you. Okay, so let's move on the next talk. The fourth topic is from Dr. Jones. The title is Tongue and Pharyngeal Pressure Modulation in Early Stage Parkinson's Disease. Please start. Oh, Dr. Jones, your voice.
私の名前は Corinne Jones です。よろしくお願いします。Hello, my name is Corinne Jones, and while I am sad I cannot join you in Japan for this conference, I'm honored to be able to share my research in this platform. We have no conflicts of interest to disclose. Parkinson's disease is the second most common neurodegenerative disease in the world, impacting about 1% of individuals over the age of 60. Pathology in the brainstem and basal ganglia lead to cardinal signs, which include rigidity, bradykinesia, hypokinesia, postural instability, and tremor. And while we all know Parkinson's disease also can have devastating effects on voice, speech, and swallowing. Dysphagia in Parkinson's disease can occur in up to 90% of individuals and result in negative health consequences such as malnutrition, dehydration, reduced quality of life, and death due to aspiration pneumonia. One of the main descriptions of dysphagia in Parkinson's disease is reduced oral and pharyngeal swallowing pressures. And this has been shown even in individuals in the early stages, although those are very subtle changes. Sometimes reduced pressures in swallowing have been deemed to be due to weakness. However, in Parkinson's disease, in that slide before where I had listed the cardinal signs, weakness is not present. And so it's unclear if these pressure changes are due to weakness or potentially reduced effort. In voice in Parkinson's disease, we see hypophonia. However, we know that individuals with Parkinson's disease are able to increase the amplitude of their voice when given the proper coaching. So it's unclear if that's something similar that we see in swallowing. So the aim of this study was to evaluate swallowing pressures during normal effort and effortful conditions in individuals with early stage Parkinson's disease, as well as healthy controls. We hypothesized that individuals with early stage Parkinson's disease would have decreased swallowing driving pressures and would be able to volitionally increase both tongue and pharyngeal pressures to similar levels as controls during an effortful condition. We evaluated 13 individuals in the early stages of Parkinson's disease with a mean age of 68.2 years. We defined early stage Parkinson's disease as a Hoehn-Yahr scale of 1 to 1.5, and being within 5 years of the initial diagnosis of Parkinson's disease. We evaluated these individuals in the off medication state, and we compared their performance to 14 age-matched controls without neurologic, respiratory, swallowing, or gastrointestinal dysfunction. We evaluated anterior tongue pressures using the Iowa Oral Pressure Instrument, looking at both saliva swallows and maximal isometric pressures. We calculated maximum pressures from each of these tasks, and we converted from kilopascals to millimeters of mercury so we could compare with pharyngeal high-resolution manometry, which we measured using the Medtronic system during normal effort and effortful 10 ml water swallows. We again measured maximum pressures during each of these tasks in the velopharynx, tongue base, and hypopharynx. For this study, we were interested in pharyngeal driving pressures, so we did not evaluate pressures in the UES, which is a valving pressure function. We performed repeated measures ANOVA on log transform data to assess main effects of region, task, and health, and the interaction effects. This is our data. I'll talk you through our graphs before we jump into the results. Control participants are plotted in blue, whereas individuals with Parkinson's disease are plotted in red. The darker colors represent the effortful task, and the lighter colors represent the normal effort task. On the y-axis is pressure in millimeters of mercury, and then on the x-axis is our region of interest. We found a significant quadratic region by task by health interaction, and I'll walk you through that specific finding now. So during effortful tasks, all participants increased pressures in all of our regions that we measured, except for the hypopharynx. We also found that in the tongue, in the anterior oral tongue, pressures were significantly increased during the effortful task, more so than velopharynx or tongue-based pressures. This is the same data, though on slightly different graphs. So on the left, we have data from our normal effort swallows, and on the right is from the effortful swallows, and we can compare individuals with Parkinson's disease to healthy controls. So we found in normal effort swallows, the anterior oral tongue pressure was significantly less in individuals with Parkinson's disease. However, during the effortful swallowing condition, there is no difference in anterior oral pressures, and there is also no difference in pharyngeal pressures during either the normal effort or effortful task. The limitations of this study was that the tasks were performed asynchronously, so the pharyngeal high-resolution manometry was collected first before the IOP tasks, and we had different effortful conditions. We did this because we wanted to match what has been published before, comparing normal effort to effortful anterior oral pressure, so using that maximal isometric task, particularly when describing functional reserve. And we can't do that maximal isometric hold task in the pharynx because it's quite difficult to control those individual muscles. So to conclude, we found that hypopharyngeal maximum pressures did not increase with effortful swallows, although pressures increased in all of our other regions. This might suggest that effortful swallow exercises could be limited in individuals with dysphagia and reduced pressures in the hypopharynx in older individuals. We also found that tongue pressures were increased to a greater degree than pharyngeal pressures, and this might reflect differences in motor control between the anterior oral tongue and our pharyngeal musculature. Furthermore, individuals with early stage Parkinson's disease showed reduced oral tongue pressures in normal effort, but not effortful tasks. There's also no difference in pharyngeal pressures in either normal or effortful conditions. This reduced oral tongue pressures during normal effort, saliva swallowing, thus might be due to hypokinesia rather than to weakness. If these individuals were weak, they would not be able to increase the pressures during that effortful task. Furthermore, this also suggests that functional reserve appears to remain intact in individuals in the early stages of Parkinson's disease, which suggests that strengthening rehabilitation may not be indicated in this population. I'd like to acknowledge the individuals in my lab at the University of Texas at Austin, as well as my collaborators at the University of Wisconsin-Madison. Arigatou gozaimashita, and thank you.
Thank you for your talk and nice Japanese. So, no question from the audience. So, are there questions from the panelists? Okay, I have a question. So, did you say the effortful swallow is not indicated for the early stage of Parkinson's disease? So, is it possible to the later stage of Parkinson's disease for the effortful swallow?
Potentially, yes. And so, I mean, with any sort of strengthening exercises, as was really eloquently described in Dr. Huckabee's talk yesterday, if we want to do strengthening exercises, we want to make sure that our patients are in fact weak. So before recommending any effortful swallow or any strengthening exercises for any patient, no matter early stage Parkinson's, late stage Parkinson's, other disease categories, you want to make sure that that patient is in fact weak. We don't know from this study, because I did only look at the early stages of Parkinson's disease, but it very well could in the later stages, patients in the later stages could have weakness, but that hasn't been shown either way.
So what kind of exercise do you recommend for the early stage of Parkinson's disease?
That's a really great question. It's really dependent on what the patient needs. And as of now, there's no data to show that, if anything does improve in a person with early stage Parkinson's disease and no overt dysphagia. That's not to mean that we shouldn't be doing anything. And currently I am looking into that. So stay tuned.
Okay, thank you. Okay, let's move on the next topic. The final topic is by Dr. Evangelista, self-reported measures of voice and swallowing, functional oral intake and quality of life in head and neck cancer survivors before and after functional laryngectomy for intracranial aspiration. So, Dr. Evangelista, please.
Thank you, everybody, and I appreciate the opportunity to present this research. So you can go ahead and start the presentation. Good afternoon. I'd like to thank the World Dysphagia Congress for the opportunity to present this research titled Self-Reported Measures of Voice and Swallowing, Functional Oral Intake, and Quality of Life in Head and Neck Cancer Survivors Before and After Functional Laryngectomy for Intractable Aspiration. I'd also like to thank my co-investigators at the University of California Davis Medical Center for their contributions to this research. These are my disclosures. Radiation therapy is a mainstay oncologic treatment for head and neck cancers. However, late radiation toxicities can result in sequelae that impact swallowing function. The temporal evolution of radiation-induced injury can lead to progressive motor and sensory impairments, resulting in fibrosis of the musculature involved with swallowing and lower cranial neuropathies. Late radiation dysphagia is often not amenable to aggressive swallowing therapy or esophageal dilations, since it has a more global presentation of impairments in tongue function and movement of the hyolaryngeal complex and pharyngeal constrictors. Definitive separation of the airway from the alimentary tract, otherwise known as a functional total laryngectomy, can eliminate aspiration in patients with profound swallowing dysfunction. Indications for functional laryngectomy include profound dysphagia with intractable aspiration that is often refractory to any conservative intervention. Also, recurrent aspiration pneumonias and feeding tube dependence are indications for functional laryngectomy. Vocal cord paralysis resulting in severe dyspnea requiring a tracheostomy tube in addition to dysphagia is also an indication. However, functional laryngectomy is not without its limitations. Patients will require a permanent tracheostoma for breathing. Due to the removal of the larynx rendering patients aphonic, patients will need to depend on alaryngeal voice methods for communication. While laryngectomy will eliminate aspiration, other biomechanical impairments from radiation therapy will persist. Changes in quality of life and self-perceptions of voice and swallowing are uncertain following functional laryngectomy for intractable aspiration in head and neck cancer survivors. The objective of our study was to determine if self-perceptions of swallowing and voice quality, in addition to quality of life, improved after functional laryngectomy for intractable aspiration in head and neck cancer survivors. This was a prospective longitudinal cohort study. Both patient-reported outcome measures and a clinician-rated measure were used. To evaluate swallowing, the eating assessment tool and functional oral intake scale were administered. The voice handicap index was used to capture voice quality, and quality of life was measured with the functional assessment of cancer therapy, head and neck. Measures of swallowing, voice, and quality of life were captured at baseline prior to functional laryngectomy and following functional laryngectomy at the 1 month, 3 month, and 6 months post-laryngectomy time points. 13 patients were enrolled in this study. Unfortunately, 2 patients died from aspiration pneumonia prior to receiving functional laryngectomy. The mean age of the cohort was 71 years, and all participants were male. All participants completed definitive chemoradiation therapy, with majority of patients having an oropharyngeal tumor subsite. All patients were primarily feeding tube dependent, with either no oral intake or very limited and inconsistent oral intake. All patients had at least 2 aspiration pneumonias since the completion of their oncologic treatment. And the mean time from the completion of radiation therapy to receiving functional laryngectomy was 11.36 years. The eating assessment tool is a 40-point patient-rated survey. The higher the score, the worse the perceived dysphagia. The average of the patients' EAT-10 scores demonstrated a steady improvement in their perceived swallowing function over time. For the voice handicapped index, perceived worsening of voice quality was reported at 1 month post-laryngectomy and is likely associated with a functional laryngectomy rendering patients aphonic. Majority of patients received a secondary tracheoesophageal voice prosthesis, which may reflect improvements in their perceptions of voice quality over the 3-month and 6-month time periods. The FACT Head and Neck is a disease-specific quality of life questionnaire that consists of 27 questions in 4 domains. The domains are physical, social and family, emotional, and functional well-being. The highest score is 148, with higher scores reflecting a higher quality of life. Consistently improved quality of life was reported over time. In regards to oral intake, 100% of patients had improvement in oral intake. 63% of patients resumed oral intake and underwent feeding tube removal, as evidenced by an increase in functional oral intake scale scores of equal to or greater than 5. This indicates that majority of patients were able to achieve complete oral intake with at least some dietary modifications or compensatory strategies. 36% of patients remained feeding tube dependent to some degree due to underlying comorbidities such as quadriplegia or severe bronchiectasis needing increased nutrition. An overwhelming majority of patients remained free of pneumonia, while one patient experienced aspiration pneumonia due to leakage from their tracheoesophageal voice prosthesis. In conclusion, functional laryngectomy for intractable aspiration in head and neck cancer survivors markedly improves self-perceptions of swallowing and voice and quality of life. In addition, functional laryngectomy eliminates the risk of aspiration and assists with liberation from feeding tube dependence. This concludes my presentation, and I'd like to thank again the World Dysphagia Congress for the opportunity to present this research.
Thank you so much. So, no question from the audience. Are there questions from the panelists? Okay, I have one question. Your talk is very excellent. The self-reported measures of voice and swallowing is good after the surgery. So, are there any correlation between the evaluation by the therapist and the self-reported evaluation?
Could you repeat the question one more time?
Oh, okay. Are there any correlation between the evaluation by the therapist of voice and swallowing and the evaluation by the self-reported evaluation?
Yeah, we haven't run correlation studies now, but what we're seeing is across time periods, with the exception of the voice handicapped index at the 1 month mark, that dips in terms of worsening of their perceived voice quality, everything in terms of metrics, being it swallowing, functional oral intake scale scores, and head and neck quality of life all demonstrate pretty steady improvement over time. So it'll be interesting as we accrue more patients and do any correlation studies what that shakes out to be.
Okay, thank you. Any other questions? Okay, so it's time to close this session. We thank so much for all panelists. Okay, thank you. Bye-bye.